My name is Mark Osterby. I'm the Executive Director for the Philadelphia County Medical Society. And I want to bring greetings and welcomes to everybody that are participating tonight in our cultural competency discussion with Dr. Elana McDonald. Again, I can't thank you enough for being part of this discussion. Again, the presentation is maybe 30 or 40 minutes. We'll say 30, but we wanted to have a discussion because it's the start of a larger conversation I think we all need to have. Social determinants of health, such as working and living conditions and quality of healthcare, aren't the same for everyone, as we know. Health inequities pose a serious challenge to the healthcare of our community, but healthcare providers have a powerful tool at their disposal, and we know that is cultural competency. Cultural competency in healthcare addresses the disparities that people of racial and cultural diverse backgrounds often experience. It can ensure that all patients get the care they need to live healthier lives. Again, what cultural competency in healthcare means delivering effective quality care to patients who have diverse beliefs, attitudes, values, and behaviors. This practice requires systems that can personalize healthcare according to the cultural and linguistic differences. It also requires understanding the potential impact that cultural differences can have on healthcare delivery. I have the distinct honor to introduce Dr. Elana McDonald. She's our presenter tonight. She is a board-certified general pediatrician in Philadelphia. She's also a native of Philadelphia, raised in the Strawberry Mansion section of North Philadelphia. She's a graduate of Central High, 251st class. Dr. McDonald also graduated from Temple University Honors Program, magna cum laude, with a bachelor's in art in biology. She received her medical degree from the Pennsylvania State College of Medicine in Hershey. She completed a 3-year pediatric residency at St. Chris's Hospital, St. Chris's Hospital for Children in Philadelphia in 2003. Dr. McDonald has dedicated her career for providing compassionate, quality care for underserved populations from birth to 21 years. She is the owner and chief medical officer for Memphis Street Pediatrics, Pazika Pediatrics, and Castor Pediatrics in Philadelphia. Dr. McDonald also serves as the medical advisor to the School of Nurses at several charter schools in the Philadelphia area. She is a fellow in the American Academy of Pediatrics, a member of the Medical Society of Eastern Pennsylvania, as well as the Philadelphia County Medical Society. Dr. McDonald is half of Twin Sisters Doc LLC. She created Twin Sisters Doc with her identical twin sister, Dr. Delana Warlaw, to promote healthcare advocacy in underserved populations. Their mission is described by 3 T's. Trusted messenger, providing accurate, cultural sensitive information that empowers people to take action to improve their health, leading to transformation outcomes. Twin Cities Doc educates the community about COVID-19 and the vaccine through webinars with nonprofit organizations, schools, churches, and etc. Twin Sister Doc also serves as a media medical consultant and mentor. Dr. McDonald is a proud mother of 2 sons. One's going to have a birthday in a few days, and a wife, and she's also an avid runner and loves to travel. We want to welcome Dr. McDonald, and we're going to turn it over to you at this time. Thank you, Dr. McDonald.
Thank you for having me. Just want to, as you mentioned, want to have a conversation tonight to start the conversation. We may not have all the answers, but at least we begin to start to ask the questions to move us in the right direction. Addressing cultural competency to provide quality health care. The goals of this talk is to understand the historical background of the mistrust of the medical establishment, recognize the cultural barriers that may affect the ability to provide quality health care, understand why culturally competent messaging is vital in providing quality health care, learn key communication strategies to address vaccine hesitancy. Mistrust of the medical establishment is well known and has been well documented based on past and current events in U.S. history. including but not limited to the Tuskegee experiment, during which in 1932, African American men were enrolled in an experiment at the Tuskegee Institute to study the effects of syphilis on the body. 600 men were enrolled, 399 with syphilis, 201 without syphilis. The men were never provided an accurate description of the research study. They were told they were being treated for bad blood. In 1947, the study was not stopped once penicillin had been proven as an effective treatment and cure for syphilis. Treatment was unethically held from these men without their knowledge until 1972. Ms. Henrietta Lacks was a 31-year-old African-American woman who received treatment for cervical cancer at Johns Hopkins University. Her cells, also known as HeLa cells, were considered immortal cells as they doubled every 20 to 24 hours in the lab. Prior to HeLa cells, all other cancer cells immediately died in the lab. Without her or her family's consent, HeLa cells were and continue to be used to advance medicine. HeLa cells have been used in research on the effects of zero gravity in outer space, development of the polio vaccine, leukemia, the AIDS virus, as well as other cancers. Ms. Lack's family has never received any compensation for the use of her cells to advance medicine. At a prison in Holmesburg, Pennsylvania, a dermatologist by the name of Dr. Albert Kligman from the University of Pennsylvania, who eventually created Retin-A, performed many unethical experiments on the prisoners from 1951 through 1974. This included the use of commercial cosmetics, but also entailed hair transplants, burns and radiation of the skin, application and ingestion of toxic levels of Retin-A, inoculation of the skin with Staph aureus. And although the prisoners did consent, they were not aware of the long-term effects of these experiments. Gynecologist Dr. Marion Sims was credited as the father of modern gynecology for creating tools and pioneering surgical techniques in mastering the repair of the vesico-vaginal fistula. His success came at the expense of African-American slave women, whom he performed painful surgical procedures. Dr. Susan Moore was a physician who documented her experiences with the physicians and nurses during her own admission for COVID-19 at a suburban hospital in Indianapolis. In her own words, she described how the physicians made her feel. He made me feel like a drug addict as she questioned the treatment plans. As a physician, she believed her treatment was based on race. I maintained if I was white, I wouldn't have to go through that. Further investigation showed she received standard of care, but there was a complete lack of compassion in the delivery of such care. Serena Williams, world-renowned tennis champion, shared her experiences after giving birth. With a history of pulmonary embolism, Serena immediately recognized the symptoms of the pulmonary embolism shortly after giving birth to her daughter. When she informed the nurse of her symptoms, the nurse told her she may be confused due to her pain medications. Serena quickly realized that she had to advocate for herself in order to receive the care that she so deserved. Next slide. The mistrust of the medical establishment has also developed out of implicit bias in healthcare. Implicit bias is the unconscious associations that lead to a negative evaluation of persons based on irrelevant characteristics such as race or gender. Overt discriminatory behavior has decreased in the United States, but covert discrimination and institutional bias continue with implicit attitudes that may influence provider behavior and treatment choices. As a result of such behaviors, the patients of color may experience longer wait times for assessment or treatment than their white counterparts. Providers may spend less time with patients of color. Providers may vary in the extent on how they collaborate with the patients when considering treatment options based on patient characteristics. Subtle biases may be expressed in a variety of ways, such as approaching patients in a dominating and condescending tone, which decreases the likelihood that patients will feel like they are being heard and valued by their providers. Failing to provide interpreters for proper communication, limiting the diagnostic workup, or recommending different treatment options for patients based on the assumption about adherence to treatment. Differences in behavior are based on, in part or in full, by positive or negative attitudes that providers hold towards various racial and ethnic groups. Racial and ethnic bias and attitudes such as feeling that white people are nicer than Black people, whether conscious or not, can lead to prejudicial behavior, such as providers taking more time with white patients than Black patients, and therefore learning more about the white patient's needs and concerns. There is evidence that healthcare professionals exhibit implicit bias at the same level of the general population. Biases are likely to influence diagnoses and treatment decisions and levels of care. The healthcare profession must address implicit bias and its impact on healthcare disparities. In order to deliver impartial care, healthcare professionals must be aware of any kind of negative evaluation they make due to patients' membership to a certain group or characteristic. Now that we have acknowledged that implicit bias exists, we must now address implicit bias. Recommendations to address implicit bias include bias training in all medical professions, including hospitals and delivery systems. All clinicians and any personnel interacting with patients should receive this training so they are better attuned to their biases and equipped with skills and tactics to address them. There must be interpreters for proper translation to ensure better communication between providers and their patients. There has also been a recommendation to create a chief equity officer roles throughout the delivery system to ensure health equity remains on the agenda. Chief equity officers are strategic leaders in the executive suite with cross-functional oversight of the delivery system's performance in serving the needs of patients and customers. We must also diversify students entering allied professional programs. If programs, particularly medical schools, are interested in increasing the number of Blacks, Latinx, or other racial minorities in schools, they need to create relationships with colleges and high schools to identify and expose minority students to the medical profession early. Next slide. How do we overcome the mistrust of the medical establishment? Well, that trust must be earned. Providers must acknowledge the history that has occurred. They must also apologize for that history. Once those two things have occurred, then ongoing conversations between medical professionals and patients can begin to occur. As we have discussed implicit bias, we must now address the cultural barriers that have the ability to affect our ability to provide quality care. Culture is the customary beliefs of social forms and material traits of a racial, religious, or social group and the characteristic features of everyday existence shared by people in a place or time. As physicians, we must be aware that cultural barriers can impact the ability to deliver quality care. We must understand those barriers in order to address them. When possible, we should try to accommodate cultural beliefs if there are no negative effects on outcome. For example, Albanian girls get their hair shaved at 1 year of life due to the belief that their hair will grow back healthier. We must also be sensitive when we explain to patients if their beliefs will have a negative effect on their health. We must recognize and accept informed decisions from adults about their health care if it contradicts their cultural beliefs. For example, Jehovah's Witnesses may decline a procedure that could potentially save their life if it involves blood products. Next slide. In order to address cultural behaviors, the medical profession must be culturally competent. What is cultural competency? Again, culture are patterns of human behavior that are part of racial, ethnic, religious, or social groups. Competence is the ability to function within the context of cultural beliefs, behaviors, and needs of a particular community or consumer. Cultural competency is a set of behaviors, attitudes, and policies that come together in a system or among professionals to allow a productive work environment in multicultural situations. Cultural competency is the ability of physicians and healthcare providers, as well as organizations, to effectively deliver healthcare services that meet social, cultural, and linguistic needs of patients. What is the importance of a culturally competent healthcare system? Culturally competent healthcare system helps to improve quality of care as well as outcomes. It helps to eliminate racial ethnic health disparities. Lack of cultural competency can lead to patients of racial ethnic groups feeling less satisfied with healthcare encounters. African Americans, Latinos, and Asian Americans are more likely to report they will receive better care if they are a different race. African Americans are more likely than other minority groups to feel that they were treated with less respect, such as being spoken to rudely, being talked down to, or just flat out ignored. Ethnic and minority groups have higher rates of chronic illnesses. Next slide. Why is cultural competency important to African Americans? African Americans carry the burden of high mortality and morbidity from many disease states, such as diabetes, heart disease, hypertension, cerebrovascular accidents, renal disease, and HIV. African American males have the lowest life expectancy than any other demographic group. One of the major problems is the lack of diversity among physicians in the medical field. As of 2013, US doctors consisted of 48.9% Caucasians, 11.7% Asians, 4.4% Hispanic, 4% African American, and 0.4% American Indian or Alaskan Native. African Americans make up 13% of the US population, but only 4% of physicians and 7% of US medical students. Why is this an issue? Sharing a racial and cultural background increases communication and trust. Trust is the fundamental concept of the physician-patient relationship. Trust is often defined as the belief that the physician will act in your best interest. Trust increases compliance and improves outcomes. A randomized clinical trial of 1,300 men in Oakland suggested that Black men agreed to more preventative services when it was recommended by a Black physician versus a non-Black physician. The men increased their diabetes screenings by 47%, their cholesterol screenings by 72%, and were 50% more likely to get a flu vaccine. We know that when patients are acutely ill, they will seek care and are more likely to accept treatment recommendations. However, when patients are well and need to go in for their anticipatory care, patients' trust in the medical system and the doctor increases compliance with recommendations. This is not to suggest that all African Americans should have an African American physician, but it does suggest that all physicians and healthcare providers should be clinically and culturally competent at treating all patients or all backgrounds. How do we increase cultural competency? We must teach physicians and healthcare professionals how to provide services in a culturally competent manner. Make the training standard across the healthcare system. Include training in medical school curriculum and nursing school curriculums. Institute policies that address all levels of the organization. Recognize that this is an ongoing process. Use training that focuses on increasing knowledge about groups combined with focus on communication skills and medical history taking skills. Next slide. What are the components of culturally competent messaging? We must be aware of our own individual beliefs. And if we cannot put aside beliefs that will affect our interaction with patients, then we should refer that patient to someone else for their care. We must be aware of cultural differences and be willing to accept them. Be aware of cultural practices and beliefs and try to understand why patients may not follow a particular treatment plan because of beliefs. For example, African Americans, for them, eating soul food is a tradition, but it often consists of foods that are higher in fat and sodium content, which is not conducive to a healthy lifestyle. We must also recognize African Americans don't wash their hair every day. So if we're trying to treat tinea capitis and we're talking about washing hair multiple times a week, that requires a more detailed discussion to explain to the parent why it is now important to wash the hair more frequently. What is your cultural knowledge? This is determined by interaction with patients or colleagues. Know your limitations and when to ask for help with particular populations. Adapt to diversity. By adapting to the needs of our patients, being open to different approaches, then we are likely to have much more success. Next slide. What are the keys to overcoming cultural differences? Recognize any biases you may have. Some of those biases include assuming that African American women are single, they're not interested in breastfeeding. Also assuming that spinal cord injuries are due to gunshot wounds and that the gunshot wounds are gang related. Assuming that African Americans are less intelligent and therefore unlikely to comply with recommendations. Ask questions in a respectful, non-condescending manner to let the patient know you're just asking more questions to get a better understanding of where they're coming from. What are the patient's goals? Do they understand what is the problem? What do you call it? Some patients may call diabetes sugar. What worries you most about the problem? You want the patient to tell you what concerns them about the problem. What are the roles of alternative medicines in different cultures? You want to ask questions such as, have you taken any other remedies besides prescription medications? Have you seen anyone other than a physician to treat your problem? And who advises you about your health? We must also recognize social determinants that can impact our ability to deliver quality health care. Please ask questions such as, are you able to obtain your medications regularly? Do you have issues seeing or reading the instructions on your pill bottle? Do you have to share your medications with anyone else in your home? Can you get to your doctor's appointments? Do you have a grocery store in your neighborhood? Use the appropriate terminology when talking to your patients about their health care. Health literacy is a major issue. You want to make sure that patients know the technical terms for their medical condition, but they also understand the layman terms, what the medical condition is doing to their health and how their health can be treated. And please allow your patients to ask questions. The more questions they ask, the more likely they are to understand their disease process, and the more likely they are to become compliant with the treatment plans. How can healthcare systems improve cultural competency? They must provide interpreters for effective communication, have minority staff that can interact with the patients, provide training to increase cultural awareness, use community health workers to assist with social determinants, use culturally sensitive literature. You don't want your patient to look and say, well, this doesn't look like me. They're not talking to me. Include family members and community members in healthcare decisions. Place offices in areas that are easily accessible. And be sure that the language competency occurs at all levels of the encounter, not just the clinical encounter, but the telephone encounters, the front desk encounter, the scheduling, the billing, as well as the literature that you provide them. Next slide. Cultural competency is very important as we work to overcome vaccine hesitancy. Why does vaccine hesitancy exist? There are several reasons why it exists. Of course, there is the mistrust of the healthcare establishment, which we have to work to earn that trust back. There has been a lack of clear, concise, accurate information on a consistent basis. The medical establishment and the federal government must do a better job at providing information via multiple avenues to reach various target groups, such as paper literature, TV commercials, radio ads, PSAs, newspapers for those who still read it, and of course, social media. Lack of policy and procedural information at various levels, including consistent mask wearing rules, where to go for testing, distribution of PPE in the beginning of the pandemic was very challenging and led to some more hesitancy. Next slide. We must continue to encourage and advocate our patients to get the vaccine. Be sure to ask why the patient is hesitant. Allow them to tell you why they do not want to get the vaccine. Be sure to debunk any myths surrounding the vaccine. Be clear that the vaccine does not introduce COVID to your body. It does not have a tracking device. It does not affect fertility. Social media is very powerful, and there's a lot of misinformation out there. If we don't consistently provide the accurate information in a way that people can understand it, then we will continue to see a lot of vaccine hesitancy. Be sure to address how mRNA works, that it does not alter the DNA, and that the technology did not just develop in 2020. Be sure to address the Operation Warp Speed term. Be clear that Operation Warp Speed did not abandon any safety protocols. Operation Warp Speed allowed for several agencies, private and governmental, to work together to allow for several steps in the vaccine process to occur simultaneously and not consecutively, which is typically done during vaccine development. This allowed for quicker than normal production of a safe and effective vaccine. Be sure to recommend the vaccine and why it's beneficial. One of the main reasons patients have reported not receiving vaccines in the past is because their doctor did not verbally recommend it to them. Physicians are still one of the most trusted sources of accurate vaccine information, if not the most trusted source. Be sure to address potential side effects of the vaccine, but also make sure that you stress that the potential side effects of the vaccine are far less significant than the actual side effects of COVID itself. Be sure that patients are aware that they can report their side effects that they receive after the vaccines through the vaccine adverse reporting system known as VAERS. And they can also sign up for the V-Safe program on their smartphone, where they receive messages to check in to see how they're doing after they get their vaccine. Be prepared to discuss the ingredients of each vaccine. Be sure that patients are aware that African American organizations were involved in monitoring the development of the process and distribution of the vaccine. Historically Black institutions such as Howard University, Meharry College of Medicine, Morehouse College of Medicine, the National Medical Association, the National Nurses Association, all of these organizations were closely monitoring the development of the vaccine. Not to mention, one of the lead scientists on the development of the Moderna vaccine was Dr. Kizzmekia Corbett. She was very instrumental in getting the Moderna vaccine out for distribution. Focus on the positive of the vaccine. The pandemic has taken so much from us in the last year, not to mention the loss of life. We have lost the ability to go to school, to go to college, to go to church, to go to restaurants, to go to our children's sporting events, to go to professional sporting events, to go visit our grandparents. The vaccine gives us the opportunity to get back to that sense of normalcy, where we could go to our children's graduations. We can go watch them in a t-ball game, a basketball game, send them off to the prom, send them off to college. We could return to our workplace. We could return to our places of worship. We can go to a restaurant and have dinner. These are all the things that we are looking forward to. More importantly, we want to get back to a sense of normalcy and go back to life as we know it. Be the example. Be an example if you share the same racial, ethnic background or linguistic group. Share your experiences. You can share your experiences by videos, by photos. If you have social media accounts, by all means, post it there. And explain why you got your vaccine, and focus on the fact that you're not only protecting yourself, but you're protecting your family, your friends, your community, as well as your patients. If you're not a part of the same ethnic background or community, work with trusted community partners to assist with getting the word out. African American physicians such as myself and my twin sister, we have worked tirelessly over the last year as twin sister docs to get the message out to the African American community and the Latinx community, because we know that there is vaccine hesitancy. Work with community development centers, work with members of the Black clergy. Black clergy is a very trusted messenger within the African American community. Also address issues with access by assisting with sign up for vaccine sites while at the office, or partner with community organizations to help assist people who are having problems with the digital divide get signed up. We also need to respect the vaccine hesitancy or concern. Give people the opportunity to ask questions, provide them with accurate information that they understand, and please allow them to come back and ask questions, because as they become more comfortable, then they're more likely to get to move forward with getting the vaccine. Next slide. As I end this presentation, there are key points that I would like for us all to remember. Understand the communities that you serve. Recognize our own biases. Communicate effectively with our patients. Pair with trusted messengers to get the message out. If someone does not trust the messenger, they're never going to hear the message. Provide resources that people can refer to continue to get accurate information. As we continue to do these things, we will be able to eradicate COVID-19. Thank you for your time. At this point, we're going to open up the the floor for questions, further discussions, suggestions, recommendations.
Dr. McDonald, thank you. Again, very thorough presentation, and hopefully start a discussion here tonight. I do have a question for you. We all are our associations, whether it's the AMA, the National Medical Association, and I don't mean to pick on us, I just wanted to know who does a better job of training of cultural competency. My point is, like, implicit bias or unconscious bias is such a large subject, and we do it obviously, but we want to do better. So because training in some cases could be anywhere from 3 hours, which is not going to maybe make you, it makes you aware, but it's not going to, maybe it could start to change, don't get me wrong, but as opposed to a semester-long program. What I would like to do is try to figure out how to help our members, whether anybody or not even a member, any physician in Philadelphia, to just do a better job, to be a resource for that. So help me to figure out how to offer those programs. So
I think number one is working with major systems that's doing the training. So starting from the ground level, right? So it's very difficult once you have a physician that's been practicing the same way for 20 years to change their thought process. So I think it's very important to get people early on in their training, such as medical school. We need to put these programs in place early on, and we need to frequently visit them. Medical school, residency, even after you become an attending, still have to have programs in place that are often not optional, but are required. As you are, a member of a certain hospital or society, you want to make sure that these, as you mentioned, 1 3-hour training session is not going to get it. However, if you have a session every 6 months, then that may be beneficial. And of course, trying to start the discussion to figure out which way do we go next, but it cannot be one and done. It has to be an ongoing process because we're dealing with a long history here. It's certainly not going to change overnight, but we at least need to get the conversation going.
Is there anybody else out there? You can just unmute yourself and just, please, I don't want to stop the conversation. Well, Dr. McDonald, here's another one for you. I know that we talk about different cultural groups, and there's definitely the do's and don'ts from those groups. Like, again, sometimes we don't know, meaning we just, a certain particular group wouldn't like you to question them all the time. That maybe make it more of a part of a whole holistic, with the whole family making the decisions, somebody else. So is there a place that we could go to find the do's and don'ts of different cultures? Like, it would be helpful for us to promote that?
So
are you aware?
I'm not aware of the places you go for the do's and the do's and the don'ts,
Yes.
But what I would say is that the do's is to ask questions, but in a non-condescending way. I have learned, I'm African American, I understand African American culture. However, my practice is multicultural. So I have had to learn how to interact with Latino patients, Albanian patients, Russian patients, Vietnamese patients, patients from Brazil and Pakistan. So it was important. And for example, the example I used with the Albanian family, I had lots of Albanian families, and I started to realize that at a year of age, the little girls were coming in with essentially buzz cuts. And then I finally asked, I noticed that your girls are getting a haircut at 12 months of age. Why do you do that? And it was just a question. And the mom said, oh, we cut the hair off because we believe that if we cut all of their hair off, then it will grow back just as strong as ever. And it was just a question. It was a question because I noticed a pattern, but I wasn't sure why that pattern was there. And I didn't come across condescending. But why would you cut your girl's hair off at a year of age? Just because we don't do that in our culture, that doesn't mean it's not right. So we want to make sure they were asking the questions. We know the old home remedies. Child has a fever, going to put garlic in the sock. That's okay if you do that, because that's not going to harm the child. However, please don't feed the child tons of, please don't have the child eating tons of garlic cloves. So I always say, when we look at cultural differences, what things is going to be okay for the families to do, and what things is going to be harmful to the families if they continue with certain behaviors. And when you address those things that are deeply rooted in cultures, it's important that you do it as sensitively as possible. So we always use the example as African Americans eating soul food. Soul foods, that's just a direct outcome of slavery. You had to put food together from the scraps that you received. So soul food, while it tastes great, oftentimes is not the healthiest for you. However, you have a conversation, and it may not be, well, you can never have certain foods again, but it could be, well, let's talk about, you have high blood pressure, you have coronary artery disease, and let's talk about your diet, and let's talk about things that we need to think about cutting out of your diet. And I understand that this is what you eat a lot, but we have to talk about cutting back on it and find the healthier options. So it's really the way that you approach the conversation, and letting people know that you're not being authoritarian, and you're trying to have a conversation so that you all can get to the best decision possible for the patient.
Anybody else? The conversation. How about linguistics? Again, another thing that I've understood. Again, I'll let somebody else take over. But the point is, linguistics. Obviously, you mentioned about having somebody come in and be able to interpreter for somebody that would need that. What are not only that, but I understand that sometimes it's the front office that needs the interpretation as well. So, can you comment on that, or do you know?
Important that, and I always say, your front desk are your eyes and your ears. Your front desk are literally your eyes and your ears. So it is important when your patients come into your office that they feel that they're part of the office. They're part of the office. And sometimes if someone's trying to talk to them in a language that they simply don't understand, then there's that misconnection. Not only is there misconnection, there is the real possibility that there's going to be miscommunication, and certain histories are going to be missed. Family histories, actual patient history, social history, all of those things that are integral to providing care. You must be able to have that conversation. And if the person thinks you're just muddling through the conversation, then they're going to think that you're not really vested in their care.
I will point out that somebody was nice enough to post a resource in the chat feature. We will sort of copy that and make sure that everybody that's on this call gets that resource as well. If it's okay, we'll share your slide deck as well. Now, Dr. McDonald, can we go one step further at some point? Is there an opportunity to do training at some point later down the line? People that would want to, again, we're just starting in tonight with the discussion on cultural competency. Now it's to do a training on unconscious bias, using that as an example, getting people to be aware. I don't know if there's any interest to do that, or if anybody's, anybody that's on.
I'm sorry, Mark, I'll let you finish your thought.
No, it was only anybody that's on this call that I don't mean to, listen, I am not trying to build something that nobody's interested in building. It's just that we talk often about, there's almost 20 people on this call. There's people that called in. They definitely were interested in learning more of self-awareness and to be a better physician and quality healthcare. So I always feel uplifted by this conversation. I just want to make sure that if there's another way to move it forward. Again, when I say move it forward, where do we go from here? That's the whole thing. So that's all.
Absolutely, and I'd be happy to participate in any other events. Sometimes it could just be simple scenarios. How did you view the scenario? How do you think your patient viewed the scenario? What could we have done differently to make that scenario better? We've done this a lot in medicine and other areas. Now it's bringing it to dealing with implicit bias, the mistrust of the system, all of those things. So I'm absolutely on board for that. And I also wanted to mention when you're talking about linguistics, it is hugely important to have the translation. If you don't personally have it in your office, then access to the language line, for any language, and also American Sign Language for hearing impaired. That's hugely important also.
Dr. McDonald, have you ran into a lot of challenges with your patients or perhaps family members of your patients that have the fear of taking the COVID vaccine? And if you have, how have you met that challenge?
Absolutely, we have definitely run into the vaccine hesitancy. I've actually run into it, initially in my own family also. So the first thing I address with my patients, anyone else, is I explain to them that, because the first thing they'll say is, why should we trust this vaccine? The government, medical establishment has not been nice to us for 400 years. Why should we trust this vaccine now? And what I tell people who are hesitant, African Americans, Latinos, anyone else who's hesitant, is yes, there has been a history, but you don't want to let history to dictate the present and your future. I am clear to them, let them know, as a pediatrician, I've been dealing with vaccine for the last 20 years. There's not a day that doesn't go by in my office that a vaccine is not given. It is okay to question the process, but our job is to give that accurate information. And I go over all of the concerns that they had. Why did they make the vaccine so fast? So I discuss how, they were able to speed up the process, and also continue to point out that we're living in a once in a lifetime pandemic that has killed us at such a drastic rate in the last year that we simply cannot sit around and wait for it to just go away. I also point out that we've seen vaccines work in the past. You may not have recognized that it's working, but vaccines have worked. For instance, polio. We essentially eradicated polio on this half of the hemisphere. Chickenpox. I don't want to date myself, but I've seen true cases of chickenpox. But if you ask people in their 20s, they have not seen true cases of chickenpox. And I say, well, why do you think that happened? It's because of the vaccine program. I also point out to them what happens when people back off of vaccines. Measles and mumps. We saw outbreaks of the measles in New York. We saw a mumps outbreak here at Temple University the year before last, as people sometimes opt out of getting vaccines. So I use the history of vaccines themselves and show how it has worked and point that out to them. I also explain to them that, yes, there's always a potential side effect for any medication, any vaccine that you receive. However, the benefit of the vaccine must absolutely outweigh the risk of the vaccine. And we know that the side effects of the vaccine certainly is not worse than the side effects from the COVID-19 vaccine itself. And then I also point out to them everything that was taken away from us in the last year. And as we try to build back and get back to a sense of normalcy, the vaccine is the most effective countermeasure that we have to get us to the other side of the pandemic. And we're starting to see the light at the end of the tunnel as more and more people get vaccinated. We also, we point out that COVID was the third leading cause of death in the United States last year. Again, the vaccine can effectively remove COVID from that list. So I explain all of those things to anyone who has questions. And again, I never say, well, I can't believe you have those questions, because it's important that we acknowledge the question and we answer the questions. And if they say they're still not ready, I say, well, you think about it. If you have any other questions, please come back. Please come back.
Thank you.
This is Steve Permit. Mark, I'm wondering if it might be beneficial to do a follow-up presentation with a series of case presentations, so that our physicians really can get a sense of what the issues are of patients coming into their offices where there might be some implicit bias.
I think that's a great idea.
We can do that. We can work with Dr. McDonald and others that would want to be part of that team. Certainly put that together. Yep, I think it's a great idea. Dr. McDonald, one of the other things that I recently heard, again, the majority of the medical profession believes in the vaccine. Every now and then there'll be one person, one physician that is skeptical or doesn't believe in it. So that throws that monkey wrench into all the gears, because the non-believers. So is there any advice on that? Because it goes back to that vaccine hesitancy.
Yeah, so what I always say is that anyone who's on the fence, they're just looking for that one thing to put them back on the other side, where they say, well, you know, I heard this person say that, or I heard this doctor say that. And then I go back to the statistics, and I go back and I say, we know that since December, over 200 million people have gotten at least one dose of the vaccine. The data is now showing that the number of cases are going down, the number of hospitalizations are going down, the number of deaths are going down. So I always go back to the data, and I explain to people that I'm data driven. If I am going to suggest something to you, I need to be able to give you a resource to go to and look at it and see why I'm telling you this. So it's always important to combat. If they come and say, well, this is why I don't want it, and I don't want to use the word combat, but it's always important to discuss with them and go back to the facts and explain to them why it's still important to get the vaccine.
Dr. McDonald, I want you to know that since 1998, we've had something called the Block Captain Healthcare Advisory Council. And I think you're pretty aware of that wonderful program that we have working with the Block Captains to educate them, our physician volunteers, and they used to come to our building, whether it be at lunch or for dinner, and we help them to become better healthcare consumers. So we have a meeting coming up of which we're going to be discussing COVID, but I just want you to know that as Philadelphia still lags behind the state with getting the vaccine, as you are well aware, every one of the block captains who don't have access to a computer, they can listen on Wednesday evening. And every one of them that I'm calling back with a call-in number, and Mark hasn't even heard this yet as well, they really trust the medical society. They trust our physicians. They trust the staff, all of us that they've worked with for a number of years. But I'm sad to tell you that everyone that I return their call are afraid of taking the vaccine, have not been vaccinated yet. And that does disturb me. But yet, as I get off the telephone after speaking with them, I feel that we've accomplished a little bit more, and they will listen to Wednesday. And as long as we give them a little bit more of information and trust, exactly what you had just said, just the trust of why it's so important. So again, personally for me, I want to thank you so much for your conversation tonight as we continue to try to educate our people.
It is a Herculean effort, to try to vaccinate an entire nation. But I always say, how do you eat a 2-ton elephant? One bite at a time. And
Right.
It's certainly going to take time, but as we keep getting the message out, and again, trusted messengers is so important. If people don't have a connection with you and people don't think you care about them, they are not going to listen. And even people who they do trust, sometimes they still have hesitancy, but it goes a lot further when they could connect with those persons and they trust those persons.
Dr. Ortiz, are you on the call still? She might have dropped off. She might be traveling. So again, Dr. McDonald, I want to thank you and everybody else that's on the call tonight to participate. We will follow up with Dr. Permit's idea. I think that was a good one about case studies, and then to do about unconscious bias and do maybe a series of these. We'll see how the first one goes after we do the first one. But I wanted to thank you everybody for participating. Again, just getting a little bit more educated. It's the beginning of a further discussion. Changing policy is something that the association does do. We work on that. We'll be happy to look at other policies that are existing so that we can actually do something. Anyway, again, I wish everybody, if there's no more questions, I'm going to wish everybody a good evening, but if there's not, we can still stay on and have a little bit further discussion. I didn't mean to cut it short. Is there anything else for the good of the order? All right. Again, I thank Dr. McDonald. Thank you very much. And again, on behalf of Dr. Ortiz, she had to drop off at the last second. So I echo her comments about thank you. It's a great program. So we'll be back in touch.
Yes, thank you for getting the conversation going.
Yep.
Thank
It's
you.
only the start of many, hopefully.
Yes.
Thank you.
Have a
All
good
right,
night.
everybody. Have a good evening.
Thank you, Dr. McDonald. Quite welcome.
Absolutely.